I imagine how many different types of patients and cases you saw, and how you develop your diagnose abilities. So that's what I want to talk about next. So could you tell us how do you diagnose special? I know that you're the area you really like lumbopelvic spine.
That's mostly what I see now. I see necks as well, but I don't see a lot of extremity joint problems, except as they're presenting as back pain, which are not. But no, you have to be very clear on what diagnosis means. Diagnosis simply means diagnosing the source and cause of symptoms. And so source and cause are two different things. Source is the anatomy, which structure is producing the nociception of which pain is created by the brain, from which pain is created by the brain. All right, so that's the anatomical origin of the nociceptive input. The cause is the pathology. Why does that tissue produce nociception? What's the cause? Is it inflammatory? Is it mechanical? What's the reason why it is sore, painful, or nociceptive? Then you have to add to that the influences of the pain experience. Now, the pain experience is not the tissue. The pain experience is what the brain creates from its input. And so you have, first of all, you have a neurophysiological modulating process that happens at the spinal cord and the hindbrain level. And this is not got nothing to do with your cognition or your emotion. It's simply the lower vertebral animals all have it too. I mean, we've evolved to be able to modulate our pain experience or our nociceptive experience, because that's a survival trait. If you can switch off pain when you're being chased by a predator, that's a really good thing. If you can increase the pain so that you protect an injured part, that's a good thing. So you can inhibit, so you don't further damage it by whatever. So the ability to modulate that nociceptive input is a survival development. It's just part of our evolution. And but we have evolved beyond just that simplistic neurophysiological modulation to the point where our emotions, our psychological states can down-regulate part of that process as well. So to me, the so-called biopsychosocial model doesn't capture the complexity at all. To me, you have the bio, which has got two parts, source and cause, all right? And you've got the neurophysiological, which is your neuromodulation. And then you've got your psychosocial, and everybody knows that there's at least 11 dimensions in that. So it's a much more complex than a biopsychosocial model. That's a simplistic condensation of a much more complex thing. So when I say diagnosis, I mean, first of all, I want to know source and cause, if I can. I can't always do that, of course. All right, then I want to know what the influences are. Is there sensitization or inhibition of the pain experience or the nociceptive input? What are the psychosocial factors that are influencing how the patient behaves and experiences their nociception? All right, and so that's all, to me, at one level, your pathoanatomy, all right, is your simple diagnostics, all right? Then you have diagnostics in the broad sense, which is all of that. So people call me a reductionist, and I know what that means, and it's bullshit. I'm not a reductionist. I use reductive methods at times, that is true, but I'm not a reductionist in terms of philosophical bent. So here we go. So to me, the first thing is to try and identify the tissue origin of pain. Then next thing, try and find out why that is nociceptively active. And then as part of that process, I learn what is modulating that experience. And sometimes you can't know what the pathoanatomy is because there's so much other stuff going on. That's relatively uncommon. If you're in primary care, most of what you are dealing with is the nociceptive input, and that the psychosocial, neurophysiological stuff, that will resolve itself when the pain resolves. Most of the time, not all. Some people are naturally predisposed to go crazy. All right, and certain cultures have weird attitudes to pain, and and so there are lots of stuff going on there. But the point is that in our good old Anglo-Saxon background, okay, which is what I am, white male, apparently not very popular at the moment, but anyway, a white male. But the point is, our culture is that if you cut your arm, then you deal with the cut. You don't worry about how you feel about it. Okay. Yeah. And same with a sprained ankle. It hurts like hell, and you might be worried about it, and you might catastrophize about it, and you might be a depressed person and all that stuff, but you still have to fix the ankle.